All right, looks like we're live here, Dr. Salka, and we've got glaucoma grand rounds for everyone that's made it to the right place. I'm looking at the numbers up here. We have a few more people that need to log in here, so we'll give it some time. With that being said, we'll have a few polling questions. If you guys look at your screen, I believe it's on the right side. It's a little bit different on the presenter side. You'll see polls. I'm just going to test one out here right now for everyone that's there, because with COPE, we need to make this interactive, and that's part of the interactive part. So I'm going to start a poll here for everyone to practice. Look for polls, and you're going to be able to answer. Some people answer in the chat, which is just fine, but there's a polling question right now. And I have, will the NFL fans be at the football games? And I can tell you, the Steelers just offered me a refund on my full season tickets. So I'm going to go with the majority here of where it's saying no. Or it's going to be at a limited capacity. Maybe I should put limited capacity. So that's kind of how the polling questions are going to run. If you'll see a few throughout here, I think we have 5. Again, these need to be live and interactive for the states that are out there. So I'm going to end the poll. And I'll just go through some housekeeping here, because it looks like the numbers are rolling in pretty well. So again, you're at Glaucoma Grand Rounds. You've got myself, Greg Caldwell. You got Joe Salka here. And we're both with Optometric Education Consultants. And thanks for joining us, for those who need this for credit. And thank you for those who are just listening tonight just to help with patient care. Joe, when you want me to launch the handout? Because I can do it now, or I can do it a little bit later. So is it?
Yeah, why don't we do it a little bit later, toward the end?
Okay. So we do have a handout for you guys. Probably we want to keep it somewhat secretive so that the polling questions make a little bit more sense without cheating or looking ahead in the handout. Again, we talked about the polling question. This is being recorded. So you can go back and you'll get a replay in about 14 hours from now, maybe 16 hours, somewhere in that range tomorrow. And you'll be able to watch the replay. Now, with that being said, those are timed. So I get the replay and I can download it. And we have a YouTube channel, Optometric Education Consultants. We have a YouTube channel. We have a bunch of other webinars that we've done, and some things from Quebec City. So if you guys go to Optometric Education Consultants and to our YouTube channel, you can re-watch as long as you want, because I'm not taking them down unless they become outdated. So you'll get a replay. It's being recorded, and we have a YouTube channel. About 2 hours from now, an email will be sent by myself, and it will have a survey in it. Please do that, because for the regulatory boards that are out there, we need to have the survey questions answered. How this works is it goes, Joe and I pretty much work. It goes to Webinar Jams as a cloud-based system. So then it goes to the cloud, and then it goes from the cloud or from the internet to you. And the best thing that you guys can do is just decrease your bandwidth competition at home. At home here, I have my son who likes to play Xbox, and my wife that stream TVs or stream movies on her iPad. I have them not doing any of that for the next 2 hours because I don't have the best bandwidth here. So if the most that you can do to decrease that, maybe not do emails while you're doing this, then you'll have a good experience here. And there is a reconnect button. Questions can go into the chat. And Joe, I see there's a little orange dot on my end. I'm not sure if there's any questions in there. People are just saying hi. If you can take a quick look at that, that's where you can post questions.
I'm not seeing anything. I'm not seeing anything in the chat.
Okay. So, that was just you saying greetings to all. So perfect. And then my last comment, so we can get started and finish pretty much on time, is Vanessa is our conference administrator. She'll send your information to Arbo. I will get everything, because this is all the way this works, is we know when you log on, log off by your email address and IP and all that stuff. And I'll send Vanessa a report. She'll send it off to Arbo. And Arbo's being killed with all these webinars. So it takes them about a week. And then within a week, Vanessa will also send you a letter of certificate to the email that you used to register for this webinar. So we will take care of the if you give us your ARBO and OE tracker number and all that stuff, we will upload that to ARBO, and we will send you a letter or certificate for those states that don't require ARBO. So I think that's it, Joe. I think we could probably, looks like everyone's logged in. Looks like we can get started. So if you want to go live with your screen.
All right, sounds good. All right, we're going to be doing glaucoma grand rounds.
So we're about 5 minutes into it, Joe. So we have to go about an hour and 45 minutes. Okay, take it over.
Let's just get this upset. Okay, I'll start it. Are we good now, Greg? Can we see everything?
Yeah, you're great. You look good.
All right, super duper. Well, this is glaucoma grand rounds. And we've always felt that some of the best education comes from colleagues talking to colleagues, friends talking to friends. Hey, I saw an interesting case. Let me tell you about it. And that's what we're going to do here. We're going to look at a couple of glaucoma cases, and Greg and I will discuss them. And we really didn't discuss these in advance. I did send them a handout. We may have talked about these cases before, but there's nothing that has been canned or pre-planned, and we're just going to try to keep it very spontaneous. If you have questions or comments, put them in the chat. Don't be afraid, and we will stop periodically and address those. Now, the disclosures, I'm a consultant or on a speaker bureau or an advisory board for a number of companies, including Novartis, Allergan, Glaucoma, and Bausch & Lomb, but I've got no direct financial interest in anything here. Greg?
Yeah, pretty much the same thing. As you can see here, you've got who I've lectured for in my advisory boards, and there's really no financial interest in tonight's glaucoma lecture. So.
Well, here's a question, and we're going to pose it. What do we do here? What to do? You know, in terms of glaucoma, in glaucoma diagnosis and management, I've always said the hardest part is actually making a diagnosis and a decision to intercede. You know, once you've done that, choices of therapy can be pretty straightforward. After that, one of the challenges can be, you know, is a patient stable or getting worse? And we're not going to really talk a lot about that here. Well, the question is, you know, what's our diagnosis? And what do we do here? So he's a 52-year-old male who was treated for presumptive ocular hypertension. Now, what I mean by that is he came to our university general care clinic when I was at the university, now in a medical surgical practice. But he came in and came in for a routine examination. He seemed to have elevated intraocular pressure. His initial pressure was 32 and 30 in each eye. And he was immediately put on medicine and then referred over to me in the glaucoma service. When I see him, his pressure is now 17 because he's on a prostaglandin analog. Now, when I talk with him, I find out one parent had glaucoma. I'm going to give that a maybe. When it all started out, he was pretty definitive both of his parents had glaucoma. And then he became a little bit less certain. Then he told me he was pretty sure that his father had glaucoma, but it got really bad and they took it out, which is a very spurious history, probably talking about cataract. So at this point, he's on treatment. And pachymetry, his corneas turn out to be thick. He's in the 610 range. The question is, should he have been treated and should we stop? Greg, when you're doing a glaucoma evaluation, what stuff is important to you? What do you want to know, and how do you approach it?
Oh boy, what do I want to know? Well, the optic nerve. You know, glaucoma is a disease of the optic nerve, so I always want to know what the optic nerve status is. So that is a couple different ways. One, looking at it. Two, photographing it. And if that looks normal, then I need to start diving down deeper and looking at ganglion cells, ganglion cell compromise, nerve fiber layer. And, you know, I'm lucky enough to be one of the practices that has OCT angiography to see if there's anything happening to the vessel density that's out there. I mean, I guess that's kind of the big highlights. Visual field definitely folds into the fold. That's getting into the functional stuff. But in glaucoma, I want to really know, those things. It's, glaucoma is an optic nerve head disease. So I want to know what the optic nerve head's doing.
Okay. When you start talking about OCT angiography and vessel density, you really climb that glaucoma mountain really quickly there. And not everybody's going to have access to that, or even may even be sure about what to do. I always like to break it down. What do we need for good glaucoma care? What is a standard glaucoma care? And I really think there are 4 things we need to have. We need to be able to look at the optic nerve somehow. That's number 1. Preferably stereoscopically, but we need to be able to look at it somehow. That's number 1. 2, we need to be able to measure intraocular pressure somehow. And really any of the FDA-approved devices, in my opinion, for measuring intraocular pressure are acceptable. We need threshold perimetry, and we need gonioscopy. And I'm going to say gonioscopically he was open. There was no abnormalities. With those 4 things, you're doing good glaucoma care. Now, you want to climb the ladder, throw in pachymetry. You want to climb the ladder a little higher, throw in ocular photography. And getting up to the top, we're going to look at OCT and possibly even OCT angiography. But as long as we look at the nerve, do perimetry, measure pressure, and do gonioscopy, we're still doing very, very good care. So I'm purposely not giving you all the information. So here are the optic nerves. Greg, do you want to take a crack at those optic nerves, or do you want me to read them? What's your preference?
Hey, I'll take care of the left one because the left one looks really good.
Okay. All right. So when we look at an optic nerve, there are a number of things that we have to take a look at. First, color. Is it pink or is it pale? And if you got pallor of the neuroretinal rim, I'm not talking about 95% cupped rims where you're looking at glial tissue and sclera. If it's pale, it's something other than or in addition to glaucoma. So look at the color of the rim. And these rims are pink and perfused, and I'm happy about that. 2, I want to look at the size of the optic nerve. And I do that. I mean, we can measure them. We can measure the size with our OCTs. I don't use 6 adapter lens. If I have it available on OCT, it just gives me an idea of the size. And I like to say there's small nerves, they're average nerves, they're large nerves. And what's important? Small nerves you can underdiagnose glaucoma. Large nerves you can overdiagnose glaucoma. Now there is a certain asymmetry here, and the right nerve is actually a little bit physically larger than the left. But they're both relatively small nerves. You may not appreciate that from the photograph unless I said something. Then we start looking for the presence or absence of parapapillary atrophy. In parapapillary atrophy, we're not entirely sure if it's an epiphenomenon of glaucoma or is it a pre-existing condition that makes the optic nerve susceptible to glaucoma. We don't really know. But extensive areas of zone beta parapapillary atrophy adjacent to the optic nerve is somewhat suggestive of the possibility of glaucoma being there. In this patient, there's no parapapillary atrophy. There's just a simple little scleral crescent. Then we start looking for the presence or absence of optic nerve hemorrhages or Grant's hemorrhages or disc hemorrhages. And the great thing about photographs is we can take a look at them and we can find these darn things, they can be somewhat challenging to find clinically. And I see none. Then we start to look for focal defects of the neuroretinal rim in the form of slit defects or wedge defects. When we start getting into widespread diffuse atrophy, it's sometimes more difficult to appreciate. But we see no focal nerve fiber layer defects, such as wedge defects here. And then we have to start looking, we can also look at the cup to disc ratio, and I can say probably in the left eye, we're looking at maybe about a 30% cup and maybe about a 50% cup. And there is a cupping asymmetry, but again, there's a disc size asymmetry, and that leads to a cupping asymmetry. I can tell you right now, and all the referrals I get for asymmetric cupping, the majority of times it is due to asymmetric disc size. Then we have to look for focal defects in the neuroretinal rim. And what I like to do is I like to cut the nerve in half. And I ask myself, does the bottom and the top look the same? Greg, what are your thoughts here?
Well, the left eye, again, going back to that, it looks pretty good. And I'm just going to add to your discussion there. I'm a big fan of the isn't rule. The isn't rule meaning that the inferior should be thicker than the superior neuroretinal rim, and then nasal, and then temporal, which the left eye just kind of matches that. And the scratching of my head is when we go over to the right eye. I don't think based on the photograph, and it's not 3D, so it'd be a little bit easier if I was looking with a 78 underneath the microscope. And I like a 78 because it provides a little bit more magnification. You could do a 90. You can do a 60 if you wanted to even get greater magnification. And it does look like the inferior is being violated in this, in that it's thinner than the superior. So this definitely raises the suspicion in my book, without any of the other trans hemorrhages and wedge defects, that inferior rim is thinner. So it gives me a little suspicion there.
How compelling is it to you on a scale of, 1 to 10, Greg?
Well, it's neutral. It's 5. I mean, it's right in the middle. I mean, I'm not going to call it glaucoma based on, maybe I'll even bump it up. I'll go maybe to a 7. I live on the isn't rule. I'll go to a 7 because this one isn't tilted. It's not obliquely inserted. I'm going to go 7 or 8 on this one, Joe. Because there's no disc anomalies, tilted disc, obliquely inserted. I'm going to raise it to an 8 on this one. That inferior rim is thin enough for me to call it that.
Okay, well, let's look at his visual fields. Here are his fields, and I know you're going to be doing a lecture in a couple of weeks on visual fields. Why don't you tell me what your thoughts are here?
Well, what I like to do is see what type of visual field it is. And what did you run here? It looks like a 24-2 threshold. I like turning fovea on. You guys will see whenever I do my visual fields, I like fovea on. Reason being, it's kind of a nice little warm up for the patient. It also helps know how the macula is functioning if the patient's getting the test. Usually around 36, 37, 35 is a 20/20. That's a very, very dim light. And as you know, when the numbers get bigger, it's a bigger and brighter light. So if the acuity just kind of helps me match whether they're getting it or not. I see it at CETA fast here. I like doing CETA standard very early in the condition because it does cross the threshold twice. So that's just kind of going over being geeky on what test was being done. Diving down into your numbers here. I like knowing what the mean deviation is. For all you guys out there, one of my biggest things I like teaching is that, minus 32 in a sense is a blind eye. So we don't want to get people to minus 32. So we're looking at the glaucoma hemifield test on the, let's see, which eye is that, Joe? Is that your left eye over there? Yeah, because it's nasal there. So you have them, just has it, they'll be looking at it. So the left eye, it's within normal limits, and then it says borderline on the right eye. I can't really see the numbers. What's the mean deviation minus what's on the left eye there? I can't really see it.
Mean deviation looks like a plus 0.61.
Okay, so that's great. So it's plus, and then what's the other one on the right eye?
2.3.
Yeah, so that's to me that's a mild defect. And to get into visual fields real quick and dirty, you'll learn more in the visual field lecture. But 0 to 5, I consider mild. 5 to 10 is moderate, and anything above a 10 is severe. And remember, I just said 32 is a blind eye, so half of that is 16, but that's visual fields are not linear in the decibel system. So you start getting up to minus 10, it's pretty severe. So you might have a mild defect, Joe, there in the right eye, and kind of matching that superior nasal area there too. So the visual fields are starting to potentially match that optic nerve in that right eye.
Okay, I'm going to take over for a little bit, Greg. A message came in from us. I think if somebody's having a little trouble logging in, if you want to give somebody a hand, I'm going to take over for a minute.
All right, let me see. Who's having trouble? Where can you help me, Joe? Who's having trouble? I don't see it on my messages.
It came through Facebook, Fred.
Okay.
Well, I'm going to take over here and tell you some more about this patient. These are not his first fields. These are his worst fields. And by that, I went through several visits, several fields, and pulled out the worst reliable ones I could find. Now, he obviously has a clean field in the left eye. The right eye, there's some small areas, but the glaucoma hemifield test is borderline, and I show you this up close. You got a mean deviation of minus 2.3, and there's a small spattering of points, but they're not overly impressive. Now, I will tell you, as we looked at visual fields in this person, he would be within normal, in this eye, he'd be within normal limits, borderline, within normal limits, borderline, within normal limits. Now, he was never outside normal limits here, and his other eye was indeed clean. I will also tell you, he never turned in a perfectly clean field. Next time, this point and maybe this point were abnormal. After that, maybe this point and that point would be abnormal, or maybe these three in a row would be abnormal. But there's no real consistency point by point. Now, let's talk about the role of pachymetry here. We've all taken a look at these graphs from the Oates study. And what we found was patients who had elevated intraocular pressure and thinner corneas had a greater propensity to convert from ocular hypertension to glaucoma. We also found that patients who had thinner corneas and larger vertical CD ratios, they have a greater propensity to convert to glaucoma. Now, I want to take a few moments and talk about the pertinence of this information now. When we go back to the Oates study, we see that when they had pachymetry measurements or central corneal thickness, average was 555 to 588, thick was above 588, and under 555 was considered thin. But I think we all learned in probably first grade of optometry school that average pachymetry is around 545. So what we thought was average falls into a thin category according to the study. I'll explain to you why that is. There are some patients who are in this study who didn't belong in this study. And they're actually probably normal people. Pachymetry was not one of the first things that was tested in this study. It was not one of the initial parameters that they looked at. It wasn't until the study was well underway that they considered the impact of pachymetry. And when they retrospectively went back and looked at these patients, they found it was a skewed population. That there are people who were skewing to the right, meaning that there's an abnormally high population of thick corneaed people. Or it's like saying, what's the average height in America versus the average height in the NBA? A skewed population. And there are a number of patients who probably got into this study with a normal visual field, a pressure of 23, and possibly a pachymetry of 620. And we realized that was probably an overestimated IOP reading. So there were a number of patients in this study who were actually probably really normal and were only ocular hypertensive based upon a Goldman applanation and a thick cornea. And these are not people who were ever going to convert to glaucoma. Now, what about this aspect right here where we happen to have a thinner cornea? All right, a thinner cornea and a larger vertical CD ratio. One may ask, why is a large cup to disc ratio a risk factor? The real reason is they also had some glaucoma patients in this study. And it was, of course, inadvertent and accidental. In order to be enrolled in the study, patients needed to have elevated intraocular pressure, normal optic nerve, normal visual field. So patients would be enrolled, and visual field would be done, and would be sent to a reading center in the Pacific Northwest. They determined the visual field was either normal or abnormal. Then optic nerve photographs were taken, and they were sent to an optic nerve reading center at Bascom Palmer. And many of these patients were being disqualified based upon the optic nerve appearance. And so many patients were being disqualified, the study was not going to be completed. So they had to go back and basically lump these patients back in because they did have normal visual field, but in this population here with a large CD ratio, if you were to go back and examine their initial baseline photos, you would find out they actually had pre-parametric glaucoma. It's not they converted, they already had glaucoma, their glaucoma just got worse during the study. So OATS study, big population, 1,626 people, but there are people who are likely normal, and there are people who likely had glaucoma that were in this study. Greg, are you back? Okay. Now, one thing I want to point out, always remember, in glaucomatous visual fields, this point is not abnormal, and this point is not abnormal. Really, the whole hemifield is abnormal. Greg, you back?
I am back.
All right.
And our colleague is in, so I didn't really get to hear what you said, so I apologize.
No worries. We're up to the polling question number 1 if you want to launch that for us.
Okay. I think I can do that. Should this patient continue with medical treatment? So again, everyone, go to the polling section and you'll be able to answer yes, no. This is an easy one with only 2 possibilities, 50-50.
And I think it's going to come down to 50-50.
So, Joe, I know you're live and you can't see what I see because I can see all the different things here. And right now, as people are rolling in with their questions or with their answers to the question, it's 83%, 84-ish, the 80% that are saying yes, and about, let's just say 20%. It's kind of fluctuating, 20% saying no. So we got majority at 81 saying yes, this patient should continue with treatment.
Okay. And there are a lot of arguments that can be made. One can say, well, he's got very thick corneas and he falls in that category of not likely to get worse. And other people can say, well, he does have pressures in the 30s. I don't feel comfortable with that. And this is one of those situations that we can argue and debate all day. What I want to throw out to you is the nerve fiber analysis. Now, this was actually a GDX, same principle pretty much as OCT. What we can see here is a pretty robust nerve fiber layer in the left eye and a relatively poor nerve fiber layer in the right eye with a great degree of inter-eye asymmetry. And if we look as to where is the greatest departure from the normative database, we can actually see that it is indeed inferiorly. So as we go back, we take a look, I think maybe that optic nerve looks a lot more notched now, doesn't it, Greg?
Absolutely, yeah.
Yeah. So you're entirely right. There is some compromise. You know, it isn't terribly compelling, but we have to notice it. Now we look at the visual field, and I told you he's never turned in a clear visual field in his right eye. As I was saying, that point isn't damaged, and that point isn't damaged. The whole hemifield is damaged. You have a high degree of retinal sensitivities. So this is probably the earliest defect you're going to see in a glaucoma patient is the shallow fluctuating scotoma. And for me, if I see defects in the same hemifield or certainly the same quadrant on 3 successive fields or 3 out of 4 in a row, I consider that to be very, very compelling. So as the disease progresses, these become more stable, they become more dense, they deepen, there's less variability, and that's what we have. So putting together structure that looks like an abnormality of the neuroretinal rim, function, there is an abnormality in the visual field that is persistent. There are risk factors. And even though he has a thick cornea and no parapapillary atrophy, he's actually a patient who is glaucomatous. So he had glaucoma, definitely in the right eye, ocular hypertension in the left eye. He was treated. And here's some visual fields over the course of about, give or take, about 15 years. He really showed no change.
Hey, Joe, stay right there. And which eye had the glaucoma? It was the right eye,
Right eye.
correct? Which eye do you have up here right now?
Right eye.
All right. And now what I want to point out here is because I get real geeky on visual fields, as Joe mentioned, I'm doing a course here in a few weeks. But everyone, other than the fact that, maybe you say that he got better because you see that uphill trend, also you took the stress off of the retinal ganglion cell. And we have seen, and we've been taught that, glaucoma can never get better. We have seen now with OCT angiography and OCTs, nerve fiber layers, and in this case, you can see right where that cluster is, where a bunch of, Joe, if you can point it out because you have control of the pointer, where there was a big cluster of visual fields done down here in the trend analysis right there. And then if you see as the next three go on, it kind of trends up. And when you take that stress off, you can allow, and that's why false positives or false negatives on a visual field can be a sign of glaucoma, because the retinal ganglion cell is wounded. It's not dead. So when you stress it the first time, it just takes a little longer to recover. So it's sometimes false positives can be a sign that the patient is glaucoma. False positives kill a visual field. So it's kind of neat how that's trending up there. That's even a better shot right there.
Greg, any questions come in the chat?
I don't think so. Let me click on it. I had the next polling question ready to rock and roll. Oh, yeah, there is. How long do Drance hemorrhages last, or how quick can they disappear? I'll reword it that way. So I'll let you take a crack at it, and then I got an answer too. So
I think generally the consensus is about 6 weeks.
Yeah, and that's what I would have said. So when you have a patient that comes in with a Drance hemorrhage, you're always kind of lucky because you caught that 6 weeks of where that glaucoma is out there, and I think the consensus too. If it's glaucoma, you have a patient with glaucoma, they are progressing. If you haven't diagnosed them with glaucoma, because Drance hemorrhages can be non-specific. There could be a PVD there, could be a disc hemorrhage, but when it's associated with glaucoma, it's glaucoma and you should treat them, reevaluate your glaucoma treatment, or if they have glaucoma, they are progressing. I think we've debated that enough in all the different societies that if it's glaucoma and it's a Drance hemorrhage from glaucoma, that they're progressing.
Yeah, I mean, I was always of the opinion that they were a risk factor. Everything showed there was a risk factor in all the studies. But I think the answer to the question is what causes the hemorrhage? Was it ischemic or was it mechanical? I think our enhanced depth imaging OCT studies have shown that it's mechanical shifting of tissue. And if the tissue is shifted, that's not something that's going to bounce back. So I would tend to say that it does tell me something has physically changed. Well, here's a case that just isn't clear. A 24-year-old female who has blurred vision in her left eye, which happens twice a year since she was 7 years old. It would last several days at a time. She's never sought medical care and it always got better. This time she decided to get medical care. Now, I was impressed by this history. I mean, I think for her to verbalize that was very impressive to me. And how I met this person was at the university. A student and a resident came up to me, and they told me they'd been refracting the heck out of this patient for about 30 minutes, and they could not satisfy her. Now, for 30 minutes, they were vacillating between +1/4 and +1/2 in the left eye. 2015 right eye correctable, 2020 left eye, but she just kept saying it wasn't clear. They're cleaning the lenses in the phoropter. They're doing everything. They can't satisfy her. Now, pupils are normal, confrontation field, medical history is unremarkable. And going by the history, the recurrent nature of this, put something into my mind. I had my Dr. House moment. And without telling them why, I just said, stop refracting the patient. Go and look in the anterior chamber and tell me what's going on. And they scurry off, and they're gone so long, I forget that they're there. And about 25 minutes later, they come back, and they tell me, we can't really judge the anterior chamber because the cornea is too cloudy. At this point, I knew I was right. So I interjected into the case.
Well, kind of being a little bit of house there, and we've actually been binge watching it because I used to watch it here and there, but kind of a cool show. We've been watching it recently with all these different streaming things on TV, and I would probably walk in the room and say, 24 years old, you don't have glaucoma, and I would preface it as you don't have primary open-angle glaucoma because I don't know of any patients that I have. Now, Joe, you're maybe a little different, but for primary open-angle glaucoma, you don't have primary, but we can start thinking of the secondaries in this case. So,
I mean, between 20 and 40 per year that I would diagnose with POAG, 1, 2, maybe per year, very rare. Well, her conjure's clear, but she did have corneal edema. They're keratotic precipitates. Chamber is deep, really couldn't assess the reaction. Pressure is 21 and 70. Greg, thoughts here?
Yeah, I like 70. She's got some type of glaucoma. It's a secondary.
Yeah, I mean it's pretty definitive. Given the choice of seeing a patient with a pressure of 22 or a pressure of 70, I'd rather have 70 because 22, I'm not entirely sure what I exactly want to do. 70, I'm pretty sure I'm going to do something.
Yeah.
Greg, why don't you launch polling question number 2?
Okay. While I do that, Ken, and since we're kind of just starting case 2 here, we have a question for case number 1, Joe. And It says, for the last case, did you only treat one eye or prophylactically both eyes?
Great question, and I'm glad that came up. The answer is I treat both eyes. And I'm gonna play this off of you, Greg. And here and this is why I'm gonna treat both eyes. Greg, let me ask you this. Is family history important to you in glaucoma?
In general, yes. Yep, family history is important, yes.
So if
confirmed glaucoma, yes.
Yeah, confirmed, close. Parents, siblings, children, yeah, we all agree that that's pretty important, right?
Yep.
You know what's more important to me than what happened to the patient's family?
What's happening in the other eye.
What happened in the other eye?
Yeah, exactly.
If there's a risk factor and one eye got glaucoma, I have every reason to believe the second eye is going to be glaucomatous too. So if family history is important to you, then fellow eye history should be very important to you.
And here's another thing that we can point out. We're all taught in school that, kind of do monocular trials. Well, I'm not sure what age span is on this webinar tonight, but, a lot of us in school were taught to do monocular trials. Well, that's kind of gone out the wayside because we've done enough monocular trials where we've put the drops in one eye and miraculously the pressure went down in the other eye. Are you sure you didn't get a little bit over there? There is some neuronal crossover. We all know that, right? So we really don't do monocular trials. And in this case, like Joe said, we're treating the one eye. That's stronger than family history. Glaucoma is a bilateral, unless it's a secondary glaucoma, but primary open-angle glaucoma is probably going to affect the other eye. Might as well treat both eyes. That'd be kind of my 10,000-foot overview of saying that. So,
all right, let's do our polling question number 2.
Okay, I'm going to launch it right now. Let's see. I want to make sure that the results are going to be published. So, with this case that we started into, the second case here, what is the most likely diagnosis? And we have given the choices, or Dr. Saka came up with these polling questions. So he has come up with acute angle closure, uveitic glaucoma, Posner-Schlossman syndrome or glaucoma cyclitic crisis, and steroid-induced glaucoma. So we got some good jockeying for a position here. About 3% so far have said angle closure. 2% have said angle closure. We've got a uveitic glaucoma sitting at about 40% and about 60% that are saying 54% that are glaucomatous cyclitic crisis, and no one has taken the bullet on the steroid-induced glaucoma.
And we gave really no history of steroid use, and yes, that's what the patient has. She has Posner-Schlossman syndrome or glaucoma cyclitic crisis. And here is a centrally located keratotic precipitate. This was actually another patient. But this is very characteristic, and the anterior chamber reaction is very, very, very mild. It's maybe a less than grade 1, but the keratotic precipitates and the precipitously high pressure and lack of symptomatology is pretty significant here. This is an idiopathic, idiosyncratic disease. Now, what do I mean by idiopathic? Well, it's inflammatory, but there's not much inflammation. And everybody calls this a trabeculitis, and that most inflammations in the trabecular meshwork. The rub here is nobody's proven that. There's no proof of that. That's only speculative. And there is a lot of relationship with viral disease here. It is very characteristic of a virus. It is unilateral, it is recurrent, it is self-limiting. They have actually found cytomegalovirus and herpes virus in the anterior chamber of patients with glaucoma cyclitic crisis. They've also found patients with glaucoma cyclitic crisis not to have any viral antigens. But I think even though it's considered idiopathic, probably there is a viral etiology, and it may be in the cytomegalovirus or herpetoviral family. So I do believe that this is a virally induced type of condition. I think the evidence is strong enough that I feel pretty comfortable saying that.
Hey, Joe, I got a question for you before we launch off at polling question 3 here. Is our colleagues 54, I already reset the poll to get ready for the next one. But I don't know, it was 55, 54 that said, Posner-Schlossman. But then there was like 40% that said uveitic glaucoma. Other than Posner-Schlossman or glaucoma cyclitic crisis being more specific, could we give credit for uveitic glaucoma? Because isn't that what this is?
In a sense, it is. Now, there are many phases of uveitic glaucoma, and I think glaucoma cyclitic crisis of Posner-Schlossman syndrome is its own distinct entity within there, but it is an inflammatory glaucoma. But frank uveitis can cause a secondary glaucoma. Acute anterior uveitis, if the pressure or if the inflammation is profound enough, you can have synechia and blockage of the trabecular meshwork with inflammatory cells, proteinaceous aqueous. It becomes like motor oil. It can't get out of the eye. The highest pressures I've ever encountered were inflammatory, and I remember one uveitic patient, I couldn't measure. It was off the tonometer scale. It was so high. But those are people who have a lot of inflammation, and they tend to be younger people. But the more common approach or more common presentation of uveitic glaucoma is an older person with a chronic low-grade smoldering iridocyclitis. The person who's been limping along on a 1+ cell for several days, several weeks to several months. Now you have steroids involved, you have proteinaceous aqueous, you have inflammation. So older people with chronic uveitis can get glaucoma. Younger people with a lot of inflammation get glaucoma. This is a very unique type of hypertensive syndrome. But yes, it is a uveitic.
Okay.
How about polling question number 3?
We are launched. And it says, which medication would be most beneficial in managing this patient? And we have topical steroid, topical prostaglandin analog, Comagan or Cosopt combo, cycloplegic or oral Diamox. I'm going to reach up here to the chat. We have a question in here that's rolled in. I'm not sure if it's coming, Joe. It says, what do the optic nerves look like? So that's a question that has rolled in. Back to the polling question. Which medication would be most beneficial? And we have topical steroids at 45%, And then we have a prostaglandin at 10% and the Combinagan or Cosopt at 15. No one's biting on cycloplegia, and we got some oral Diamox here at about 30%. So your top two are steroids and oral Diamox with no cycloplegia, prostaglandin analogs, and Combinagan. Then Cosopt are about equal right now, all about, say, 12 or 14%.
Now, interestingly, a case can be made for any of the choices. If you're limited to just one, steroids are what's going to work. And I've had patients with a glaucoma cyclitic crisis where the patient was in the mid 30 range, where I've only treated with steroid. Now, cycloplegic, they generally, you're not hurting a person. In fact, you very rarely can go wrong to cycloplege. They just generally don't need it, not like a true uveitis, and they tend to be more disturbed by the treatment than they do the disease in that situation. Diamox, carbonic anhydrase inhibitors, or combination agents will help lower pressure, but we really need to address the inflammation first. Now, prostaglandin analogs, this is inflammatory. Are you hurting the patient? No, you're not. You're not going to hurt the patient. You may not have the same degree of effectiveness that you would expect with a prostaglandin, but you're not going to hurt a patient at all. But first and foremost, it really probably should be a steroid. So what happened, I don't usually lower pressure in the office unless it's acute. I actually did this more as an exercise for the students and residents. In office, use Predforte, Timolol, Alpha-Gan, and Trusopt, each separated by about 5 minutes. After 30 minutes, pressure dropped down to 50, and the cornea cleared. Vision went right back to normal. She was happy as can be. Repeated the regimen, comes down to 35. She's certainly out of the woods. Sent her home with a steroid and an Alpha-Gan to be used 3 times a day. Brought her back in 1 day for follow-up. Pressure's 10. Optic nerve was normal. Probably about a 0.3 CD ratio in each eye. Perimetry normal. OCT normal. Optic nerves all normal. So here's a patient who's been spiking to this level, because I know at a pressure of 50, she's asymptomatic. At a pressure of 70, she's symptomatic, and she has repeated symptoms. Is this atypical? Well, somewhat. This is not a totally benign disease. That's one thing I think we need to understand. About half of these patients will develop a glaucomatous type of atrophy. About half the patients I've seen with glaucoma cyclitic crisis did develop true glaucoma changes. When they have recurrence and they spend more and more time spiking, and when they spike, they're very, very stereotypical. They go to the same level. I've had patients, I could predict what their ILP would be within a couple millimeters. They'd spike to 50 every time, or between 50 and 55, or if they were spiking to 30, 30 to 35. But the more times they have the spikes, the more time they spend at these levels, they will get glaucomatous type of atrophy. Is it a variant of uveitic or a real diagnosis? Both. It's uveitic, but it's its own diagnosis. And is it a herpetic variant? I think the evidence is probably sufficient to say probably. Greg, any thoughts here?
No, I think you hit them all well. We did have a question roll in here. It says, will the KPs remain?
No, they'll burn off. That's what the steroids will do. Steroids will burn off synechia. Steroids will burn off the keratotic precipitates. They're going to burn off pretty quickly. They're not greasy or mutton fat. They don't really get that sticky.
Yeah, they don't get pigmented, and and it's because it's a low grade uveitis. If it was more of a full grade 3 or 4, you'd probably stick around, but there's probably a more of a bigger secondary cause, rather maybe these antigens that are floating around. So in Posner-Schlossman, 99.9% of the time you can expect those KPs to disappear.
Well, I always like to say, for the most part, glaucoma is predictable. And here's one that I would say predictably is going to have a bad prognosis. She's a 78-year-old 78-year-old female who had an average IOP in the low 20s when I first met her. She had thin-ish corneas, but she had exfoliative material in both eyes. She had clearly pseudoexfoliative or exfoliative glaucoma. Gonioscopy was open with moderate pigment, as we would expect. But she's got this whole issue of pseudoexfoliation or exfoliation. Greg, I use the term exfoliation myself. I don't call it pseudo, but I know we tend to vary back and forth on this. Do you have any thoughts on this matter?
Yeah, I mean, I like to call it exfoliative material. It's really not pseudo. I mean, it's there, it's produced, and from being in the Glaucoma Society meetings and just knowing that this material, they've tried destroying it, lasering it, putting it in acid, once you get it out of the eye and how tough it is. I mean, it's not pseudo, it's real. So
yeah, the whole issue is true exfoliation of the lens capsule only happened very rarely with high irradiance. And that's why they called it pseudo. But the issue here is that material, that abnormal basement membrane, gets laid down on the surface of the lens, and as the iris rubs across it, it rubs it off and rubs the pigment off. So it's the exfoliation of this basement membrane that's really the problem. So that's why I like exfoliative myself.
And to take it even a step further, and then we have a question, Joe. I'm not sure if you want to wait to the end of the case from the previous case, but to take it a step further with this exfoliative material, it's been found in other organs of these patients. It just really hasn't been linked to any other, is it heart failure or liver failure or kidney? They found it in other organs and throughout the body. It's kind of a systemic type of condition. It just can really wreak havoc on the eyes that's out there. So,
Greg, any thoughts on the optic nerve or visual fields here?
Let's see. Well, I mean, just looking at it looks like the left optic nerve here. It looks like you might have something kind of coming out superior temporally. Doesn't really match the inferior neuroretinal rim on the optic nerve head. So I mean, potentially, I'm not sold that you might have a superior defect in both eyes on the visual fields.
Yeah, it's kind of, she has cataract and a very light colored fundus, but she's got some early disc damage, early field damage, but nothing is terrible. However, she's got this really bad disease. An exfoliative glaucoma is the worst chronic glaucoma you're probably going to encounter. They have higher pressures. They're going to need more medicines, more likely need laser, more likely need surgery, more likely become visually disabled. Most ophthalmologists would tell you that this is a really bad disease.
And it's usually in my opinion, just as you're saying there, most, Joe, it's probably the most asymmetric that I see out there. It usually can beat the hell out of one eye and sometimes luckily leave the other eye pretty well alone. It's a pretty asymmetric disease. I've seen some 9-0 cups and, the other cup being 30 or 40%.
So, diagnosed exfoliative glaucoma. Now, considerations, she has mild field loss. She's older. The baseline IOP is not that high, but she does have exfoliation. The question is, can this patient be monitored or should she be treated? I think most people would always advocate you should probably treat a patient like this. Well, patient declines treatment. She tells me she's had bad experience listening to doctors in the past. And she's more afraid of the treatment than she is of the disease. Now, I prescribed a prostaglandin. I sampled her with a prostaglandin. She went home, she opened that product insert, read every word, and was more afraid of a prostaglandin than she was of glaucoma. And she called me the next day and said, I believe you when you tell me I have glaucoma, and I'm not going to go blind overnight, am I? And the answer is, of course, no. I said, well, how about if you just follow me over time, and if I don't get worse, I won't be bothered. And if I do get worse, then we can talk about doing something. And I told her that was probably not in her best interest. I had recommended treatment, but she declined. Because everything here tells me she is likely to do poorly. I will tell you. Eventually, her pressure climbed to 34 and 37. Greg, what are your thoughts here?
Well, it certainly fits the disease. I mean, that exfoliated material gets into the tracheal meshwork, the inflammation starts clogging things up. So it's kind of typical with this condition.
So now we have this older woman who's now peaking. She goes from the low 20s up into the mid to high 30s, and she's got exfoliation. What are you anticipating to happen here, Greg?
Well, you would anticipate that over time she's going to lose nerve fiber layer, ganglion cells. She's going to have a visual field defect that worsens. But we've been fooled in the past. So, but I think the majority of the patients, especially as they're older, they're at definitely increased risk of having more damage than not damage.
Mm-hmm. And before anybody asks, or if they're thinking about it, trabeculoplasty she did not want. Cataract surgery she did not want. She had rigid gas permeable lenses. She loved them. She's happy with her vision. She wants no interventions. And this is what happened to her visual field over the course of about 10 years. Greg, you want to make some comments here?
Yeah, looking at the looks like on the picture on the left, that looks like the right eye.
Correct.
And over 10 years, not a dramatic decrease. You can see the predictive of 5 years is not anything earth-shattering here. Looks like she had a bad visual field there, just that one outlier, about 5 back from where the last one was. And then the left eye is not crashing anything quickly there. And if you get down and look at the progression analysis, she's got a few spots showing up. So she's tolerating the spikes pretty well.
Yeah, and that is the very atypical, unpredictable nature of glaucoma. I would expect that this patient would have progressively gotten worse over the course of 10 years. She essentially didn't. Now, if we take a look at the rate of change that we've measured over 10 years and predicted, what's the difference now? Now she's in her late 80s.
And cataracts.
Mm-hmm. So now but she's happy with vision, doesn't want cataract surgery. If we extrapolate out, if nothing changes, what is her risk of future vision loss in 5 years? It's actually very negligible. But what would be the difference? Now she'll be in her early 90s. Now, interestingly, early in our time together, and she was actually a very good glaucoma patient. She came in 4 times a year. I could photograph her. She'll take visual fields. She just would not want treatment. And then we start getting up to around here, and nothing has changed. After every visit, I would tell her I would recommend that you start medicine. And she'd say, "Thank you, I'd prefer not to." Then after about 6 or 7 years, when nothing has changed, she'd ask me, "What's my pressure?" I say, "It's 28." She'd ask me, "Is that good?" And my response is, "Oh, apparently for you it is." So risk factors of exfoliation, high pressure, older age, no progression. Now, interesting, Greg, one time she came in, she shared a new concern with me. She had noticed that her eyelashes were getting kind of thin, and she had heard about this new medicine that would make her eyelashes thicker. So she won't use Lumigan, but she'll use Latisse, or putting it in other ways, she won't use bimatoprost, but she'll use bimatoprost. And I thought I was onto something, but she ultimately backed off of this. Now, what else happened? I remember I was doing this some time ago, and I was going to update her visual fields, and I looked because I was only at 2015. And I went into her medical record and saw that I actually had the last visual field, and I saw that she had missed her last appointment with me, which is very atypical. So I called my front desk and I said, "Please, she's been a bad girl. Get her back on my schedule. I need to see her." This is maybe about 6 months after her last visit. And a couple minutes later, I got a call from my front desk, and they said her phone's been disconnected. I did what I usually do in a situation like that. I put her name into Google, and first thing that came up was a link to her obituary. She died 2 months after our last visit of natural causes. She had ostensibly a bad disease that should have blinded her or at least made her visually impaired. She used no treatment and was never bothered for the remainder of her life. Greg, any thoughts here?
Yeah, just that it's just atypical for that to happen, but is enough glaucoma that we've treated over, whether it's primary, secondary glaucomas. That's the beauty of glaucoma; it can always fool you, and sometimes the patients might know their body best. But the best thing to do, the best thing that would happen to you on this case was she was a good glaucoma patient. She did come back every 4 months,
Yep.
So that could allow you to exhale. So. There is a question that rolled in.
Okay.
It says, because of this type of glaucoma can affect other organs, would blood work reveal anything?
The answer is no. There is some abnormalities on the loxal genes, but genetic testing is not going to be very helpful. The answer is no. It has been found in the blood vessels. It has been found in the heart. Is there any systemic testing? To my knowledge, no. That is good. That is a good question.
Yeah, that's a great question. Going back to the previous case, Joe, the Posner-Schlossman, we did have a question to roll in that says, if they have a history of herpetic disease, should one put them on chronic antiviral to prevent transient spikes?
That is a great question, and I actually had skipped over that. I sometimes will discuss that. The answer is it's extremely off-label. Now, what about the patients who are getting worse because they have recurrent attacks? This is worth, I guess, worth a good discussion. People who have recurrent attacks. Well, you can't put them on steroids forever because you will give them glaucoma, you will give them cataracts. Putting them on glaucoma medicines, they're using medicine that is not beneficial for the greater part of the year. Actually, if you look at the literature, the recommendation, believe it or not, is trabeculectomy. Doing trabeculectomy to mid out the pressure spikes that may occur. Now, I personally think that's a bit overly aggressive. So here's what I would do in a situation. I have done this actually. I explain to patients my thought process and the evidence that this might be viral. And with their consent, I will put them on acyclovir. And I put them on the same amount of acyclovir as they did in the HEAD study to prevent recurrence, 400 milligrams twice a day. And I just keep them on that. I've done it with a handful of patients who were repeatedly spiking. And my experience, limited though as it is, it did seem to help. I had one person who would have a spike to 55 every 3 months. And when I put him on acyclovir, he went a year with no outbreaks. And then he ran out of his prescription, didn't realize he was supposed to refill it after a year. And 3 weeks after he stopped using it, he had an outbreak. He had a spike. But here's something else. I had another patient who, over the course of about 15 years, had 20 events. And he had lost nerve and he had lost some vision. And predictably, it stopped. And I'd seen him for about 15 years. He kept a log of all his outbreaks. He knew everything about his very intelligent fella. And after 15 years, it just stopped happening. So that's something that is a possibility, is it could burn itself out.
Yeah, I'll throw a 2 cents into that, is that if the patient is a cold sore sufferer, that might be a question that you could ask. And if you put them on the 400 milligrams twice a day of acyclovir, if you're looking for the Valtrex or the Val acyclovir equivalent, you could do 500 milligrams once a day. If they come back, because they'll know right away if they're a cold sore sufferer. Oh my gosh, yeah, I get them all the time. okay, you might have yourself a link there. I do a herpetic, every A to Z herpes, da 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 da. And one of the things I treat a ton of herpes in my area. Even the ophthalmologists don't even want to treat them; they send them over. And one of the biggest things that I find to make it easier when someone wants to go on chronic medication like that, because it's cleared through the kidneys. You got to be careful with it. So make sure if you're going to put them on that you get the kidney function test, or at least let the PCP know. Is one of my easiest ways to do it is, hey, you a cold sore sufferer? Oh my gosh, yeah. Because by treating the eye, guess what? You're probably also going to treat the cold sores, and they're not going to get so many. So you're going to make them happy two ways potentially. So that would probably be the question I would ask on this patient is that, if they're a cold sore sufferer, hey, you want to try something for me? It's not really proven, but your eye pressure keeps going up. You got these cold sores. We might be able to treat both of them at the same time. So that'd be my 2 cents.
Greg, here.
We just got another one to roll in here. It says, regarding the same thing, being as its viral nature, can Posner-Schlossman syndrome be found in coronavirus patients?
In coronavirus patients, I've not heard anything. I think we're too new into this to know. And I'm going to say it's presumptively viral. They've actually tapped the anterior chamber of patients with glaucoma cyclic crisis and found no virus in some people. And other patients, they've actually found cytomegalovirus. So it's not definitive.
Right. I agree. Yep.
All right. I always say all glaucoma is not created equal. Greg, she's a 71-year-old female who was diagnosed with glaucoma in 2009 and treated with Travatan with a good response. And this is by a local OD. He made a good diagnosis, good intervention. Pressure drops down from 28 down to 18. Average pachymetry. But he didn't feel comfortable with the severity of the disease, so he asked me to see the patient. And I saw the patient probably for a visit or two. Angles open, no evidence of secondary glaucoma. There are the visual fields that were sent over from the referring optometrist. Greg, is anything atypical or unusual to you here?
The image that you have on the left kind of looks like your typical glaucoma patient. What I don't like is the macula being involved in both cases. The image that's on the right here, they're just boxes. I love looking at the data that's at the top. The raw data, obviously you have it in there for a reason, or not showing it for a reason, but are they zeros? Are they, 15s? Are they 29s? Are they bright lights, dim lights? And then, it looks like you might even have a rim defect over there on that right image. But, it's, you ask if there's anything there. It looks like the left image looks glaucomatous. The right image potentially macular degeneration with the way that's looking, and then maybe some glaucoma defect or a rim defect. So,
but she was a person of African descent, so AMD not likely. You're right. There are some visual field defects, kind of getting kind of close to fixation. But let me throw this to you just superficially, Greg. 71-year-old female, average pachymetry, pressure 28, prostaglandin drops down to 18. Anything funky here? It's just pretty much garden variety open angle.
Yeah. I mean, nothing.
I probably saw her for 2 visits, and then she transferred care to a local ophthalmologist out of convenience. Now, that was 2009. In 2012, she comes back to me. When she comes back, and she's been under care of a good practitioner, she comes back to me. She's 20/30 and 2400 now. She tells me she's had trabeculoplasty twice in each eye. She's now on Lumigan, Comigan, and Azopt. Had used an oral carbonic anhydrase inhibitor 3 times per day, but couldn't tolerate it. Had used pilocarpine, knew this word, gave her motion sickness, she couldn't tolerate it. And her pressure is 22 and 38. Greg, what are your thoughts here?
Well, pretty advanced.
Is this anything you would have predicted?
Oh, no. No.
Exactly. So she has open angle glaucoma, and she has what appears to be a very aggressive form. And here are her optic nerves. Now she's come back to me, and I'm going to become her practitioner. I can't get a visual field in the left eye because of the vision. I can't get anything reliable. That's her right eye. If you see where she started, she started like that, and that's where she is now. Anything come to mind, or anything you want to throw out here, Greg? Or
No, I'm just kind of looking at the visual fields here, looking at the numbers. It looks like a minus 18, minus 19. So we're getting close to that minus 30.
yeah.
Yeah.
So how are you going to approach this patient now?
Well, at this point, if it's related to glaucoma, I'm going to be trying to get her to have some type of surgical intervention. So it's beyond topical. It's beyond, I think what's out there in the realm. We're talking I don't even think it's MIGS. I had even attempt MIGS on this. I don't think an eye stent would be good. Maybe a Cahook dual blade, but I think with this amount of glaucoma, we're talking getting into express shunts with trabs. But Joe, I just kind of looking at the one optic nerve head there. Is it worth talking about peripapillary atrophy? I think sometimes people get confused on alpha and beta. Is there anything that you can point out there?
Well, there's peripapillary atrophy here, and the zone beta is that pale area adjacent to the temporal rim, and that's more associated with glaucoma. As you go a little further out, you might have this pigmented area, and they call that zone alpha. And I'm not really sure exactly how that relates to glaucoma. It's been said that it really doesn't, but the zone beta adjacent to the optic nerve is more significant. But Greg, I agree with you. In fact, everybody agrees.
Except the patient, right?
No, the first thing the patient said when she came back was, "I know I need surgery. I've been told this. I don't want surgery." Okay, Greg, now what?
Max her out as much as you can with topical drops. She's already had SLT done. I mean, you can't do any MIGS without it. So, you go with your glaucoma regimen that can lower the IOP the best, and without kind of compromising her life, putting drops in every hour.
It's my supposition that she got good care. It's not like she disappeared. She got good care in the interim. I think the ophthalmologist realized that he was out of options and wanted surgery, and that's when she came back, because she didn't want to hear that. All right, so I renew her medicine. She comes 214, and she tells me, she's not been seeing very well in her left eye since about the previous September. Now she's 20/50 in light perception in the left eye. Her pressure is 36 and 30. Declined surgery again. And of course, in the chart, always write, you recommend surgery, discuss risk and benefits, explained most likely way the patient will retain vision, patient declines. Greg, do you fire people from your practice for this? What do you do?
Am I firing the patient? Is that what you're saying?
Yeah. Do you fire patients?
No, I mean, they're allowed to make decisions. You make the recommendation as long as as I think you said earlier, as long as you mark down that they decline surgery, you've gave them the best advice. They're going to go blind. They're going to lose vision. Glaucoma leads to blindness and vision loss. And as long as you're documenting it, I'm okay as long as the patient understands. Now, the only other thing that I would ask is she okay? Everything's systemically going on? Is she taking her medications the right way? Are we missing something carotid-wise? I think with the pressure's high enough, I think I have the reason why she's losing and having this optic neuropathy. But I just want to make sure there's nothing else systemically going on, I guess.
No, there isn't.
Okay.
Then she no-shows, but did request medication refills for the previous year, and I refilled them. Then she comes in one day using Comigan only, had run out of Azopt and Travatan. She's 20/60 and no light perception, and her pressure is 46 and now 72. No inflammation, open angles. Status post SLT twice and using Comigan with a pressure still of 72. All right, so refill the medicines. Of course, we have the discussion, decline surgery yet again.
Yeah, I would beg and plead for that right eye to try and do something. The left eye is obviously NLP now. Right now, the left eye is at 72 is just keeping it comfortable. As long as she doesn't have any cornea breakdown, bulle forming at this point, the left eye is lost now. I think it's all hands on deck and making sure, she's now 2060. Is this where she wants to go?
Yeah, we had the conversation, and I even offered to, talk with her family, and she said no. That's not necessary. So I can't do that without her permission. And in fact, at one visit, her son was in the waiting room. I said, "Do you want me to bring him in?" "No, I'll tell him everything." So obviously, she didn't want that to be done. She didn't want communication with her family. 615 comes in, was using meds regularly, was confused when to use Travatan, didn't use in the past week, vision's unchanged. She's 20/40, now she's in 53. Now she has new views on surgery. Now she tells me, well, if I had vision in my left eye, I would do surgery in my right eye, but because I don't have vision in my left eye, I'm too nervous to do it in my right eye. And unfortunately, this all came a couple years too late. And once it is almost understandable, because she did ask me, she asked me point blank, if I have surgery, will it stop vision loss? The answer is you can't guarantee anything. A person can have a complication in trabeculectomy and lose vision. They can have no complication and still lose their fixation. Or they can have no complications at all, the surgery is successful, and the disease progresses. So when she asked me, could you guarantee I won't lose vision if I have surgery? The answer is we can't make any guarantees. Any final thoughts there, Greg?
No, I don't. Nothing I can add to that.
Any questions roll in?
No.
Okay. All right, let's look at all the data and see what we want to do here. 62-year-old female comes to me as a glaucoma suspect, 20/20 in each eye. I don't know what the pachymetry is. It didn't get done at any prompt time. Pressure is in the 17 to 18 range on multiple occasions. Biomicroscopy is normal. Angles are open without abnormality. Greg, how do you feel about looking at these OCTs? Do you have any thoughts here? I know you use a different device. Do you feel comfortable talking about this one, or do you want me to talk?
Well, I can kind of look at it and make a few comments here. Just looking at the nerve fiber layer, the T-snit on this image on the left. I don't have control of the pointer there, but on the keep coming down, like right in there, that's a little. To me, when you look at OCTs, it's all about symmetry. There's the eyes are usually pretty symmetric. I don't like that, so I would definitely look at the scan and make sure the scan is a reliable scan. And if it is, then that would give me a little bit of concern right there. So,
you point that out, and yes, but you see it's still in the green, but this is much more in the green now. As I look at this, this is a device I have a fair degree of comfort in. I like to look at the thickness map. And the thickness map looks pretty darn good there. This one does not. And that, to me, looks like a wedge defect. And when I look down here, everything falls within the normative data range. Now, the qualifications here are, when you look at these, understand there's a lot of anatomic area being averaged in. And when things get averaged in here, small defects, when it gets averaged in a larger area, can fall within the machine's normative database. But I take a look at this, and the thickness map in the cirrus is actually one of the most sensitive measures out of the whole printout in identifying nerve fiber layer loss. Now I come over here, and There's a very, very good nerve fiber or ganglion cell complex here, but right there, obeying the horizontal raphe, it looks like a nautilus shell. On this device, when I see that nautilus shell appearance, I immediately suspect there's something truly wrong. Even though everything falls within a normative data range, that cut obeying the horizontal raphe and looking like a nautilus shell, to me, is very compelling, especially when it matches. And this defect are really part of the same defect. So this looks pretty suspicious to me, or I'd say abnormal in the left eye, even though everything falls within the normative data range. There's too much hinkiness here.
Go down to where you are with your numbers there, Joe, on that right image in the ganglion cell. And can you point out that it looks like it's 88 and 72? Is that what that has?
88 and 72, yes.
So I'm going back to the asymmetry part. And Joe keeps mentioning about the green disease. Nothing's being flagged here, but there's still asymmetry. And people always ask me, like, what's the number that I look for? 10 microns of asymmetry in reliable scans is enough for me to scratch my head. 15 for sure. So when you're looking for those micron differences, that's enough right there. And even in that other image down there, in that inferior temporal quadrant, I think you're showing 147, and then you're dropping to the other one still in the green is at 90. So you got some asymmetry down there. So even though the normative databases say green, as long as the scans are reliable and clear, asymmetry can be your friend. So,
and curiously enough, you notice that there are some things that are above the normative data range. All right, what do you think about this now, Greg? The visual fields.
So what was the eye that was questionable? The left eye? Is that what the? Yeah. So, okay. Now these are reversed because now this is on the left. This is the right eye, and the right eye is on the left. So, I don't know. I mean, not really matching. You got maybe a central defect over here on the left eye. Certainly not matching anything with that inferior nasal defect, and they're very mild. Looks like -1s. The pattern standard deviation is kind of low, meaning scattered, and you got the other eye saying outside normal limits, and the suspicious eye saying within normal limits. So.
Yep. So somewhat contradictory findings, and one can say there are things here contradictory as well. Patterns that are very suspicious still fall within a normative data range. Okay, what do you see here, Greg? It is an optic nerve disease.
Yeah, in that looking at the left optic nerve, it looks like there's a nerve fiber layer wedge defect. So,
indeed, there is. And what else do you notice? There's a disc hemorrhage.
Yeah.
And we go back to an older photograph of this patient. There's no nerve fiber layer defect, but several years earlier there was a disc hemorrhage, which progressed on to this wedge defect, and this wedge defect matches what we see here very well. And that's why I like the thickness map here. It matches these defects very, very well. Now we take a look, and I actually ran this on 2 different OCTs. And one thing you notice is, yeah, Greg, there is that asymmetry. And on the spectralis, it does fall outside of normal limits, but with the Cirrus, and I'm not saying one device is better than the other. They're all very complementary. We can see one falls within the normative data range and one falls outside the normal data range. Greg, any thoughts here?
Yeah, I think you're hitting it perfectly. I mean, the databases and the ranges, you got to cut it off somewhere. So the scientists have to do that. And that's kind of why I've kind of cut my teeth in interpreting these is, asymmetry. And now it's being flagged over here on the spectralis, but geez, if you go up to the T-SNP, that is definitely flatlining on that left eye right there. Yep.
And we take a look at them, we can see that there is an asymmetry there, clearly. And there's an asymmetry there. It just does not meet the criteria on one device. And of course, not every practice can have 2 or 3 different devices. So your assessment can be all very well dictated by what technology that you use.
I'd like to, before we launch the polling question, is, and Joe has said it, I've said it, I'm not sure who got it from who, and we maybe got it for someone else or whatever, but glaucoma is a disease when you're looking at the OCT. It's an inferior or superior temporal disease. Don't look nasal, don't look temporal. You look inferior temporal and superior temporal. So that's, when you hear it's like when I look at all these quadrants and I'm looking at all these pie sectors, I'm looking like what Joe has here on this image, bottom left-hand corner, on this left eye. I'm looking at that 125. I'm looking at that 89. I'm going down there. It's a little blurry on my end, Joe, so I might have the numbers off. 88, and it's 93. But then I go to the other eye in that inferior temporal. I'm looking at 147 and 77 and going up superior, that 149 number. So, they just wanted to point out that glaucoma is superior temporal and inferior temporal disease. Now, some people say it's always inferior and always superior. It's not. It's going to be superior or inferior, but you're going to look superior temporal or inferior temporal.
Agreed. Why don't we hit polling question number 4, Greg?
Sir, let's see. I think I have it, the right one here. So
I think that's an easy one.
All right. Yes. Does this patient have glaucoma? Yes or no? Go to the polling questions for everyone that's still here. And I think it's on the right-hand side. Go to polling, click on it, and I think you'll be able to now click in your answer. So people are weighing in here, Joe. Right now, it's about 93% that are saying yes, and then 5%, 7% saying no. Make it simple. We'll say 90% yes and 10% no.
And I think when we look at the recurrent disc hemorrhages, the acquisition of a new onset neurofibrillary defect, the fields are not supportive. We can call this probably pre-parametric glaucoma in the left eye.
And I'm going to change that a little bit. And I agree that with what we have with the terminology, we would call it pre-parametric. But do our perimeters, are they sensitive enough? Are we testing in the right areas in a sense? We have targeted perimetry. So it's maybe pre-parametric, but that's based on maybe the technology that we have too. If we run maybe the proper visual field, targeted visual fields, which are really not out there yet, but they're in the testing institutes, you probably would find a visual field defect. So it's still within the practitioner's world where we still call it pre-parametric based on what we have in our offices.
Hey, Greg, what do you make about this? 63-year-old female who's ocular hypertensive. I said, I think it might only be ocular hypertensive in one eye. Had been treated with timolol before, but didn't do very well where it had some fatigue, and she stopped it. She was being followed without treatment for every 6 months, and then 6 months become 18 months when she shows back up. Now, I'm working with a resident. He wants to do fields and OCT, but what did you say about glaucoma being an optic nerve disease? Let's look at that too.
Right.
Well, here's what we have. Her pachymetry is thinnish at 512 and 509. We can see where her pressures are. It looks like she's really only ocular hypertensive in the right eye. Open the ciliary body, gonioscopically, everything is fine.
So at the beginning, I know I was offline trying to help one of our colleagues. Did you get into the as my drum solo, as you like to say, is about adjusting IOPs up or down? Did you get to talk about that?
No, I did not.
Okay, so I'm going to take because every glaucoma lecture that I do, until I quit getting letters and seeing people doing this, I mention in every glaucoma lecture, and I'll keep it short, is that, based on these 500s, if the IOP was 15, I would not say, it could be 17 or 18. The biggest reason is we don't know what the corneal rigidity is. And the corneal rigidity could be high, could be very titanium-like, it could be rock hard, it could be really soft, and you could be going the wrong way. So basically use this 500-ish is a little bit increased risk for glaucoma. Please do not adjust IOPs up or down based on glaucoma or based on PAC imagery readings. I saw something in my office the other day that we were handing out cards in the ocular hypertensive treatment study, and it was an IOP adjuster. And I'm keeping it now I'm going to put it in one of my lectures. Please do not adjust IOPs up or down based on PAC imageries. So thank you.
Here are her findings. Here's her OCT individual field. Robust, okay, robust nerve fiber layer, robust ganglion cell complex. The fields are fine, and this is, these were from probably 2 years earlier. And I know my resident wanted to, he wanted to repeat the OCT and want to repeat the visual fields. But what I recall on this patient was I had a lot of data on the optic nerve and some very good optic nerve photos. So I said, you got to remember, it is an optic nerve disease. Let's just actually take a look at those. What do you think here, Greg?
Well, from 2013 going over to 2015 on the right eye, is that a Drans hemorrhage inferiorly?
It is.
Okay. Or is it a disc hemorrhage? So it's a disc hemorrhage. Mm-hmm. So to me, if that's associated with glaucoma, we've got some progression. And it looks like coming right out of that Drans hemorrhage that there could be maybe some nerve fiber layer defect there. The left eye is looking real close back and forth, looking pretty much the same.
Mm-hmm. Now, the importance of this is, if we had just done an OCT or visual field, would we have seen this? The answer is no. That's why we have to look, because I can tell you right now, when done, the OCT was unchanged, the visual field was unchanged. And had we not looked, we would not have seen this change somewhere down deep in the laminar cribrosa. Now, what did this impact? What would you do here, Greg? Is this enough you'd start treating this patient?
The answer is yes. I would make the recommendation to the patient that we could consider start treating, or depending on how quick I'm following them, if it's a 6-month follow-up, I might shorten it. But I would definitely explain to them that, anytime you have this hemorrhage and this stress going on, that it's moved into damage. And it'd be kind of neat. Can you go back and look at you probably don't have that today's, the 2015 nerve fiber layer maybe. But you might pick that up on maybe some thickening there, because there could be some swelling, but then you bring them back in a few months, you might start seeing the atrophy start occurring on this patient as this disease progresses. But yeah, to answer your question, Joe, this is enough for me to really be stressing to the patient, look, there's a disease out there called glaucoma. It's a disease of the optic nerve. It slowly progresses over time, and you're showing progression. And we need to, at some point, it doesn't have to be today, at least if we see the changes that we don't want to be seeing, then we probably should be treating. So,
yeah, we had that conversation, and treatment was advocated, and she actually declined. She wanted observation, and we had a very, come to the Lord talk here, that you can't come back in 18 months. I want to see you back in 3 or 4 months. And she was pretty good about that, and probably within a year, her visual field and her nerve fiber layer did change, as would be expected. And at this point, she was more compelling, and she underwent treatment at that point. Greg, is non-compliance always bad?
No. We've proven that many a times. The patient disappears. We make a decision in April of 2018, and we see the patient back almost 2 years later, and you do the testing, and nothing's changed. So non-compliance is sometimes good.
Well, here's a patient. Let's take this. This is another ocular hypertensive patient. We can see pachymetry, she is definitely on the thick side, 605 and 604. We can see her pressure is pretty much average in the low 30s. She's peaked at 34 in each eye, but generally she's in the 32 range. She's got a very small C. But if you notice, her visual field, her optic nerve progressed. It stayed progressed, and it got better again, which is kind of underscoring how inaccurate CD ratios can be. Inter and intra-observer variation is just too great. Gonioscopically, she's well open, and she looks like this. And any thoughts on the data here, Greg?
I mean, the visual fields look fine. I'm just trying to look at the the one scan. It looks like the left eye there. You kind of got that little big spike there in the nerve fiber layer. At least that's what I appear. I don't read those all the time.
No, that's actually neuroretinal. That one there is neuroretinal rim. I'm not sure how much I believe that.
Right. Okay. There's a T-snit down below, looking very symmetric. Even going down below, white is white, so that means it's thicker than the green. I'm really not seeing anything in that. I can't see the numbers real well, but it looks like the superior inferior temporal where glaucoma occurs looks like to be spared. So,
and the optic nerves are small with very small cups. So let's kind of figure this out. Her pressure is consistently about 32. Her pachymetry is about 605 and 604. You see what her optic nerves look like, and you see what her visual fields look like. We have to decide, do we treat or do we observe? And I think that brings us to our last polling question, number 5. Greg, why don't you launch that one?
I'm going to launch it, and then it's really easy. It's, should this patient be treated prophylactically, yes or no? And again, I'm going to go back on my soapbox here while we're waiting for the polling question to roll in here, is that, Joe mentioned that IOP is 32 on average with a 600. Don't think that now, based on those thicker corneas, is 28 or 26, because the true intraocular pressure could be higher. It could be 34. It could be 35, because we don't know all the cornea dynamics. We don't know corneal curvature, how it's affecting the tonometer and the cornea rigidity, and all the different corneal dynamics that are out there. So all we know with that 600, it's decreasing the risk.
And what does our poll say, Greg?
Yeah, they're rolling in here. We have no winning at about 60%. So this patient should be prophylactically treated. No 60%, and yes 40%.
Okay, interesting. Pretty close. I thought it'd be 50-50. And I will tell you, Greg, personally, on the day that I saw the patient, I said, I think we should treat you. That was my inclination at that day. We had some discussion. I said, she asked, what would you do? And I said, I think we should use a medicine. And her response was, I'd rather not. Can we just watch it? And the answer is yes, we'll watch it. But I want to see you back in 3 months. Okay, 3 months was follow-up was scheduled. She returns promptly 3 years later. And she looks like this. Any thoughts here, Greg?
Looks pretty stable.
Yeah, no change. So while I wanted to, or I recommended treatment over observation at this, she apparently chose observation, comes back 3 years later, and now there's been no change. And we consider the fact that her pressure has been in the 30s for a couple of years before that. We've got a long period of time where this patient has shown no change. So I guess we can say is, what was her target pressure? I don't know, 30? Any final thoughts here, Greg? Anything you want to add?
No, I thought it was a good case. Most of the times we'd be recommending it, but kind of moves along that line of, I've definitely, with cases like this, have followed a lot more cases over the years, and using the technology now, and as long as the patient shows up, meaning, Yeah, I kind of, like I mentioned earlier, I'm kind of lucky. I kind of have two structural tests, OCT, which is neurofibrillary, and GCC. Another structural test now, which is the capillary densities around the optic nerve and in the macula, right where the neurofibrillary is in the GCC. So another structural test with OCT angiography and a visual field. So these cases have proven to me that, ocular hypertension, I don't mind following, and that's what this patient is. She's got a pressure of 30. That might sound scary, but drops create irritation. They're a cost to the patient. I certainly don't mind following them with the analogy too, with them or being clear that if they start to progress, then we're going to treat them. So
I think a lot of these cases underscore a lot of good glaucoma understanding. I think one thing we need to understand is we don't know, or we can't predict every case. We all have different approaches, and in many cases, there are different options that are probably equally good for a patient. So we have to remain open-minded, understand the disease, the predictability and sometimes unpredictability of it, and just do the best we can with these patients.
And I think family history plays a role in following some of these patients too. The fact that, if they've had those close family members go blind from glaucoma, I'd probably be a little bit less likely, and so would they be a little bit less likely probably to follow and monitor. I think the patients that have seen loved ones, close loved ones, lose vision from it, that would probably be treated. But if it's one of those where did this come from? No one else in my family has it. Then I think I'd probably lean on, okay, let's watch it and see what happens. So that'd be probably some more final thoughts.
That is an interesting thing about family history. And I've been in situations where I diagnosed glaucoma newly on a person, and their response was, but nobody in my family has glaucoma. And my response is, well, Lennon and McCartney weren't songwriters, so they wrote their first song. Now they're songwriters.
Right.
It does begin somewhere. And then I've also had those patients who were always fastidious about it because both parents had glaucoma, and they're deathly afraid of developing glaucoma, and their pressure is 14 with a 0.25 CD ratio in each eye. And I tell them, I said, my analogy is, in my opinion, Paul McCartney is the greatest songwriter of our time. Has his kids written any hit songs? Absolutely not. Doesn't mean you got to get it.
So we have a question that has rolled, and that's a great analogy. I like that one, and I'll probably use that in the office. We have a question here, a couple questions that have rolled in. One is there an increased risk of a central retinal vein occlusion?
That's a great question. The answer is, in my opinion, no. I've seen a lot of central retinal vein occlusion in glaucoma patients, and virtually they're all patients who are being treated. And the OAT study actually answered this question. They looked at patients who were treated versus those who were observed with ocular hypertension. And they saw there was a small difference, I think, over 11 years. They had about 26 vein occlusions, and they had more vein occlusions in the untreated higher pressure group than the treated group. But the difference was like 2.3% versus 1.4%. Their conclusion was lowering pressure is not necessary to, preventing vein occlusions is not a reason to do it. And I've had patients pressures in the 60s and 70s who don't have vein occlusions. I think that it is probably an overrated fear, but a good question. But I think it's overrated. Like I said, I've had 50s, 60s, and 70s without vein occlusions.
I think this question was answered by one of our attendees. The question was, does the last patient have systemic hypertension? And someone replied yes, but I don't remember, Joe. It was your case. And
which one here? The very last one?
I think so, yeah.
No, she had ocular hypertension, but not systemic hypertension.
Okay. And then we have kind of a longer comment here. great case and a real key to dealing with glaucoma. Most of us see slowly progressive glaucoma in our patients with the disease, but there is a subset, like this lady who may be more malignant form, and he has malignant in quotations, of glaucoma. How do you recognize this subset of aggressive forms of the disease? What clues of picking up the patients earlier are real key to this disease? And that's true. I mean, I live in an area where my population is a white population, and the key is when we diagnose primary open-angle glaucoma, are they the rapid progressors, or are they they're slow progressors that are out there?
That is a great question. I know exactly which case he's talking about. The woman who just got progressively worse. Yes. The answer is we don't know. We can only say a patient is well controlled if it's in retrospect. Now, a patient comes in with pressure of 30. We put our prostaglandin on. Pressure comes back at 15. We say well controlled. Well, we can only say is the medicine lowered the pressure by 50%. In 5 years, if there's been no changes, we can say they're well controlled. But we can only say well controlled if it's in retrospect. And can we predict? The answer is no. That's why we have to follow the patients closely. Every 3 to 4 months is appropriate. That's what I do. And I'm going to go back and I'm going to lay down one last analogy. Okay, we look at risk factors. We try to predict, but you don't know. One person may be Keith Richards. One person may be Keith Moon. You know, two people who had risk factors for an early death. One person died early. The other person is going to be on tour next year. You just don't know till you follow them over time. Sometimes we get surprised, but that's why we follow them. We just can't predict.
Yeah, and I think that brings up, a good clinical pearl is that, pretty much anytime I diagnose, and probably most of us diagnose glaucoma, I say to them, look, I'm going to follow you closely for the next 3 or 4 years, definitely 3 years. We got to look for these rapid progressors. Once we get out 3 or 4 years and we have a pretty good feel, then they might, if I see them every 3 months, that's 4 visits a year. If I see them every 4 months, that's 3 visits a year. I'm doing that for 3 or 4 years, and then I might back off at year 4 if I'm starting to feel good about them being a slow progressor. So you can't tell until you follow them. So
that's great. But then again, when you get to year 10 is, I think, when you start to follow them a little closer, because that's when a well-controlled person will start to slip a little bit in my experience. Greg, I don't think we want to go any further. We don't want to wear out our welcome. Always leave them wanting more than overstay your welcome. And we only got through about half our cases, so maybe we'll come back in a couple weeks into the second half.
Okay, sounds good to me. With that being said, we needed to get to 8:45, and we're at 8:48. So this will conclude the webinar for tonight. Joe and I would like to thank everyone for attending. We hope that you found something to go back tomorrow, if you're in patient care tomorrow, to help your patients with glaucoma. I'll make a final reminder to everyone that, Vanessa is our conference coordinator. She's wonderful. I'll get her a list of who was on the webinar tonight, who needs credit. She will this week get that off to Arbo and Cope for those who need the OE tracker number. Like I mentioned earlier at the beginning, the Arbo and Cope, they're a little bit backlogged with all the webinars going on. So within about a week, you'll get a little email from our OE tracker knowing that it was uploaded. Also, Vanessa will send you a letter of certificate of attendance for tonight. So that takes about 4 or 5 days. If some of you guys are up against the timeline, she can usually crank one out a little sooner. So just email us and we'll see what we can do for that. So give us about a week. Arbo, get us about a week to get your letter of attendance out so that you can have the credit. And again, I want to thank everyone for being here tonight. Joe, I'll take it over to you for final comments.
No, I don't have any final comments other than be safe. We're learning and teaching in a different manner. It's a new world. Hopefully we'll be back to our old world before long. So I just want to say thanks for attending. I know you have other options, and we're trying to help out and meet people's needs. And I hope everything works its way out and everybody stays safe.
Thank you. I'll echo the stay safe. Thank you. Bye, everyone.
Peace and love.